Well, welcome everyone and happy Monday. Welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course I am here with Chief Medical Officer of the Centeno-Schultz Clinic in Boulder, Broomfield, Colorado, Dr. Chris Centeno. Good to see you, Doc.
Good to see you, Jason.
All right, everyone, we are back to talking about PICL procedures. Today we're actually speaking about the fact that many of you may not be aware that there are two types of PICL procedures. There is the above the atlas, below the atlas. Today, Doc, let's break down the differences between the two. Who needs which one when? Let's break it down.
Yeah, so just to give everyone a 30,000 foot view, this is the PICL procedure, which is injecting the ligaments that hold the head on. And these are patients who have had an injury to those ligaments and who are pretty disabled from that injury. They've got craniocervical instability. So the PICL procedure involves injecting those ligaments, trying to get them to heal and tighten up so these patients can avoid a fusion, which would be normally bolting together those upper neck bones. So that's what we're talking about here today. Now, the procedure itself has kind of two versions. One is an under the atlas, the other is over the atlas. And so what happens with that is that when we first started doing PICL, we went under the atlas. You can see my cat here. That's Hannah. What that allows us to inject is the transverse ligament, the accessory ligaments that come along the side of the alar, and then those bleed up into the alar ligaments. So those are the things we can inject. Now, it's more the lower portion of the alar ligaments. You know, we see all these diagrams in books, and frankly, regrettably, the real stuff doesn't resemble the diagrams a lot. More recently, over the last 6 months to 9 months, we've been doing more over the atlas procedures as well, where we can inject the upper portion of those alar ligaments and possibly even the apical ligament, and even seen a little bit of transverse ligament flow from that area. So there's really these two different procedures that are similar. Sometimes the ligaments bleed, you know, the flow bleeds from one to the other, meaning when we inject, we see it go from one set of ligaments into the other set of ligaments. But just realize that at the end of the day, there are two procedures, and we have much more experience with the first one and are now gaining experience with the second one.
Let's be clear, this is a procedure that literally you invented. And from what I understand is only available at the Centeno-Schultz clinic with you and Dr. Schultz because of the complexity of it and the specialty that it really is. Let's help people understand who may be new to this conversation, just sort of a high-level overview. What are the symptoms that somebody may have that may make them eligible for this type of procedure?
Yeah, the main symptoms that PICL patients have, or patients with craniocervical instability, headaches are a big one, dizziness, and then a whole host of other issues, problems with the eyes, problems with, obviously, when I say, high up in the neck or go over the head. So it's important to say that because sometimes people don't consider pain back here in the upper neck a headache, but we usually call it that in the medical profession. And then there are other symptoms that are shared by a good number of craniocervical instability patients. Those symptoms include things like facial numbness, or sometimes we'll see patients who have wandering pain or numbness in various parts of their body, arm, leg, shoulder, etc. So a collection of symptoms built around usually headaches / imbalance, but not everyone has the imbalance part. That's usually made worse by any type of activity. So these are not patients that can easily tolerate, for instance, physical therapy. In fact, they usually crash and burn with any type of physical therapy. They are usually made better by upper cervical chiropractic. So about 60–70% of our patients swear by upper cervical chiropractic, which gives them very nice relief for a period of time. But then they're determined to be unstable because it just won't hold.
Let's get into more details about that. Like you've just implied or said very clearly, actually, that this is a procedure that's usually not a first sign or first intervention when you have a headache or something. So sometimes people have tried chiropractic, they've tried physical therapy. What are some of the popular diagnoses that somebody might have been given from another professional that may be sort of a red flag to go, wait a minute, that might be me? I know you've mentioned upper cervical instability. EDS is another condition. What are some other diagnoses that somebody might have that would go, wait, they're talking about me?
Yeah, so listen, a lot these patients end up being a pinball in the pinball machine game called See a Specialist. And literally, the patient goes from one specialist to the next, to the next, to the next, to the next, to the next. So many times, they're worked up for dizziness. So they see an ENT doctor, they're worked up for EDS. So they might be seeing a geneticist about their EDS or EDS specific patient, meaning stretchy ligaments, Ehlers-Danlos syndrome. Many times they see an ENT for their dizziness, or they'll see a neurologist for their headaches, or they'll see a surgeon because they've got something else going on in their cervical spine. And sometimes they'll even end up with a fusion in the lower neck, but that makes them worse because then that puts the forces into the upper neck. So they see a whole host of specialists trying to figure out what's going on, and sometimes they get no diagnosis. They just sort of get stared at like they've got an eye in the middle of their forehead because the doctor just says, I don't know what's wrong with you, let me find you someone else to see, meaning, which is code for, I don't really know what's going on here, so let's get this person out of my office.
That is your you've got the power moment right now, is to understand that there are a lot of doctors that really don't understand the nuances of these conditions at this level. And so one of the ways is Dr. Centeno is saying, you may all, if you're watching, have experienced, doctors have, for the most part, great intentions, want to do the right things, want to tell you the truth about what's going on, but oftentimes don't have the information and training for these specific types of conditions. And there's not a drug, and there's really not a surgery that solves them. So it tends to sort of go in that black box of, I don't know what to do with this. And that's an issue for many of you. So if that's not you, but it's somebody you know, then please let them know that really the Centeno-Schultz Clinic is the place for help for people with these types of conditions. Let's go to some questions we've got right here. Jenna Swinger is asking, what are some of the reasons why PICL doesn't work for some, the roughly 3 out of 10 that you refer to?
Yeah, so that's a good question. So that could be procedural difficulties with the patient, meaning that, for example, we just had a patient come in who we couldn't reach the upper alar ligaments at all. In fact, we had to bring him back and do a very crazy positioning to try to get there. We were able to finally get there, but 6 months ago, we wouldn't have been able to do it at all. So there's that. In addition to that, there's whether or not that person's bone marrow has the ability to heal these ligaments. A third would be that perhaps craniocervical instability is not the diagnosis, meaning that we see patients and we try to qualify them based on a number of different things. So for instance, a history that fits craniocervical instability, predisposing factors or something that caused this that fits craniocervical instability, imaging that fits that, et cetera, et cetera. But we're still probably seeing patients within that group who don't have craniocervical instability causing most of their symptoms. There's another cause. And I know that's a very hard thing to hear as a patient, that diagnosis is not 100%. But there is no blood test I can give a patient that would allow me to say this person has CCI and this person doesn't. It's a collection of puzzle pieces that have to come together. And then the fourth might be that their problem is too severe for this type of injection-based procedure, and that person may well need a cervical fusion. So as I've always said during these talks, this is a ladder of invasiveness, and you start at the least invasive things like chiropractic physical therapy. You move up to injection-based therapies, which can be everything from injecting the posterior ligaments to facet joints, and then to this PICL, and then diffusion if none of those work. And that's the best way to keep patients as safe as possible, i.e. you only expose patients to the maximum risk who need it.
Let's break this down just a little bit. I know when I hear people say things or ask questions around the concept of it doesn't work, again, in these kind of advanced conversations, the power is in the nuances. And so some of the reasons or some of the things that people might do, and I know we talk oftentimes with the proactive membership program that you have, that sometimes people need more than one procedure in order for them to get the full effects. Sometimes they've waited too long, and so they may not get the results they are hoping for. Do you want to help people understand, whether it's PICL or this applies to all orthopedic conditions, the difference between sort of a one and done type of expectation versus a, if we can make some progress, then it's possible, again, for all kinds of reasons. Maybe they waited too long. Maybe they just need a booster of some sort. Help people understand the thinking that it's not really this binary worked, didn't work, but sometimes it's the progress that they're able to make over time, and sometimes they don't give it another, I guess, unintended, another shot.
Yeah, so just realize that we're talking about a procedure that's generally done between 2 and 4 times. It's very rare to see one and dones with a PICL, although that's possible, but pretty rare, meaning maybe 5% of the patients fall into that category. And we're increasingly able now to say to a patient that didn't get relief after the first one to be willing to go to the second one, whereas that's not something we did early on because we didn't really know the risk matrix for the procedure, meaning that we didn't want to expose someone to too much risk if the first one didn't work by going to a second one. So this is a procedure, again, that takes 2 to 4 times, but again, not perfect. Where will this end up once we, 5 years from now, once we're as good as we can possibly get at this type of procedure? And there's probably only another 10, 15% to get there. It is, maybe a success rate, again, of 70 to 80%, but that's still going to leave about 2 out of 10 patients that end up going to an upper cervical fusion because we couldn't help.
And the key is for you, those of you listening, if you're wondering, one of the principles we talk about is that these are progressive conditions that get worse over time. By definition, they are. So the sooner you get checked, get an evaluation, get a diagnosis, find out what's going on, the sooner you are able to start taking control of your condition. And I say that, that may seem obvious to many of you, but I can tell you, as a practicing chiropractor years ago, so many people come in and have waited and hoped it would go away, or hoped it would get better, or got tired of looking around, sort of gave up. Now's not the time to give up. It's your body, it's your future, it's your health. Get checked and see if help is available. We've got more questions, Doc, so let's keep it going. We've got this one submitted in advance by Charlotte Tillman, who asks, does one patient ever need both, referring to the upper and lower atlas procedures we started the conversation with?
Yeah, so here's where we are with this. Generally, we're doing the lower first on the first procedure because we have about 50, 60% of our patients that will get better just with the lower procedure. And then we're only adding the upper procedure if that's necessary at the second procedure when the patient's coming back. Now, sometime here in the next couple of months, we will have done enough above atlas to feel comfortable so that we will probably start doing it out of the gate. But we're again trying to be careful here by trying to only expose people who really need this to that additional risk. Now, what's the additional risk? The risk is really just unknown. So that's, in my book, that's risk until we actually know more.
Okay. We've got this one submitted in advance by Harry Winston, who asks, will you ever be offering these procedures in England or anywhere in Europe?
No, Harry, I don't see that happening anytime soon. That would be very unlikely. The problem is that it requires a CGMP class clean room to do this procedure, meaning that another level of processing above the level that our Regenix network clinics can pull off. Meaning in Colorado, we have $1 million clean room. And that clean room has, for instance, an air handler that's big enough to do a very large building that just does that room by pushing air through HEPA filters. So it's set up to be a clean room. Hence, and the reason that's important is the sterility issue here is huge because we're in a situation here where we don't want any risk, or at least we want to minimize the risk as much as humanly possible of introducing any infectious bacteria or other agents into this area. Number two, there are very few physicians in Europe with the skill set to do this. I know a few, but there's not that many. And then fewer here than in the United States, regrettably, because of the nature of the healthcare systems in Europe. And then third, it requires specialized equipment like specialized 3D printed mouthpieces, the use of endoscopy to visualize the back of the throat area, which is, again, all of these things sort of add up to it's very difficult to pull off outside of our Colorado site. Now, I can't say never. So, 5 years from now, is it possible that someone might be able to do this in Europe? It's possible. They'll just have to make a tremendous investment, both financially and in time, to want to do something like this, and for me to agree to train that person.
There we go. All right. The good news is it is available in beautiful Colorado, and there's hotels and planes and everything you need to get there. So your health is worth it. We've got a comment from Daniel Semrad, who says, hi, Dr. Centeno. It was good to see you last week. I'm back home and doing well. Goes on to say, feel free to discuss at a high level his case if you wish. He doesn't mind.
Thank you, Dan. I really appreciate that. Listen, I want to give a big shout out to Dan, who has just done a great job of trying to put together a Facebook group for PICL patients and trying to keep that reined in. I know it's difficult in Facebook groups. So thank you, Dan, for doing that. So from a high level, we have been able to get where so when we first started doing PICL, or I first started doing PICL in 2015, we didn't really understand how to get where we wanted to be. We had some conceptual ideas. And so as time went on, we got better and better at doing certain techniques. But we still see the rare patient like Dan, whose anatomy is just positioned in such a way that it makes it difficult to access one space or the other. And for Dan, the above the atlas was extremely difficult to do. So I had worked with Dan, and we had tried various positions during the procedure to see if we could get into that space. We really couldn't get into that space, so I had to call it. Dr. Schultz was able to see him the next day because he was in the office, and Dan, who's an engineer, myself, and Dr. Schultz extensively discussed, could we reposition Dan in such a strange way that we could possibly get into the space. And thankfully, we were able to get him in such a contorted position that we were able to gain access to the above the atlas space and inject those ligaments. So a big thank you to Dr. Schultz for taking additional time to do that, because I was out of the office the next day. And a big thank you to Dan for having the patience to put up with that. But it was one of those things where, anatomy is what anatomy is, and it comes to you a certain way, and and you try to work around it. We now know how to work around someone who has Dan's anatomy, which is an incredibly important learning point for us. It's probably only going to get used 1 in 100 patients, but it allows us to, take that 1 in 100 patient and actually do something, whereas we would have just said we can't help you before. So thank you, Dan, for helping us with that, because Dan was involved, being an engineer, in the discussions of how are we going to position you to try to get into this spot.
I just have to pause and give you so much credit and make sure the viewers are aware that it is so fresh and unique to work with doctors whose real commitment is figuring it out. Figuring out how do we best help you? How do you get the best results possible? It's not, well, that doesn't fit into what we do, so therefore we can't help you. It's when there's a will, there's a way. And that's really the difference in what you're working with when you work with the Centeno-Schultz clinic. The investment in the research, the investment in the clean room, the investment in the technology, the equipment, literally millions of dollars of investment that nobody in, I'll say, their right minds would do from a business standpoint. But you're not looking, hopefully, as a patient, to go to the best business. You're looking to go to the best doctor. That means the person who's done the most research, has the most experience, and is really committed to helping people get the results they're looking for, not just work within the system and just go, yeah, I can't help you, next. Which is oftentimes the way it is in the real world. Many of you know that from experience. You want to comment, or should I keep on going with questions?
Well, no, thank you. I mean, listen, we are dedicated to, obviously, this area. We spend a lot of time talking about all of this. And like any new procedure, patients come to you and you can't make it happen. And either you say, well, I just can't treat those kind of people, or you try to turn that into learning that can benefit the next person who comes in.
Yeah, that's a big deal and a big difference with the Centeno-Schultz clinic. Let's go with Livia Benkova, who says, what is the approximate radiation dose involved in the diagnostics and treatment of the CCI with PICL? By this, I mean the DMX at Katz, Dr. Katz, Dr. Evan Katz, great chiropractor in the area, and the X-ray used during the PICL, including fluoroscopy. Is this a safe dose given the multiple procedures that some need?
Yeah, so if we look at, I think Dan actually has has figured some of this out. He's gone back and forth with me, so you may want to contact Dan, who was just on here, about that. But if we look at other procedures that are done, so let's take radiofrequency ablation for the low back as an example. Radiofrequency ablation for the low back is where someone twice a year goes in and burns little nerves, or an epidural for the low back or for the neck, where people are getting treated several times a year, or even patients that have multiple problems, right? They've got their back, their upper back, their neck, and getting procedures and all of that, and getting 5 or 6 total procedures per year. Radiation doses for this are in that same range. So not too concerned about the radiation dose causing harm, because it's common radiation dose experienced by patients. All of that radiation is obviously going to be far below a single CT scan. So if you had to avoid one thing that you could avoid, a CT scan would be it, because that's where the radiation doses get extremely high. And then as far as the DMX is concerned, Dan Samand, like I said, has worked on that. I think DMX is relatively low radiation dose, probably on the order of a PICL procedure itself. So it's one of the reasons why, after getting some data from a research standpoint, we kind of stopped doing serial DMXs, because we're trying to limit that radiation exposure. So, and then putting it another way, your risk from a radiation exposure from this procedure, even if you got the max dose of anyone in any given year who had this procedure, would be a tiny fraction of the risk from upper cervical fusion for the procedure, meaning that the magnitude of those risks are upper cervical fusion here, radiation dosage for PICL way down there. So just realize that, again, it's relative to what, right? We've got to look at these risks from the standpoint of if someone fuses your upper neck, you've got about a 1 in 200 chance of dying from the procedure, i.e. leaving the hospital in a body bag. So that's a big risk. And then you've got about a 20 in 100 risk of a severe complication based on what's been published and based on what I've seen. So it's about 2, sometimes with certain surgeons, up to 3 in 10 patients who have pretty serious risks, at least 2 in 10 that have life-changing risks going or complications going forward. So obviously, the radiation risk that we're talking about here is not even in the same ballpark there.
Risk is always accompanied by its friend, relative risk.
Yeah, relative risk.
All right, and there's a few comments on there. In fact, Dr. Katz appears to be watching. He says, "Hi, Livia. It's a lower dose for sure." Hi, Dr. Katz. And I noticed that you mentioned Dan, and he made a comment. It says, "Regarding the radiation doses, yes, I have some of that math for anyone interested. I posted some of it in the group." So Liv, thank you for your question. Dr. Katz and Dan, thanks for your feedback and contributions. Let's keep the questions coming. Popular topic today. You're okay on time?
Yeah, and I would just say, this is one of the things I love about Dan, because Dan's an engineer, and he's not letting anyone else figure out this for him. He's got more than enough math skills to be able to figure this out. So I would go to the group to take a look at that.
Takes a team. All right. Elizabeth Yogabeth Escardo asks, what's your thoughts on ozone therapy before and after PICL?
So I'm assuming you mean ozone injections or prolozone injections. So that's where they take prolotherapy solution and they add in ozone. Let me know if it's something else. But for those, that's going to be injecting usually the posterior ligaments. So, if there's a posterior ligament problem, that might be very helpful. I kind of put prolozone in the same category as prolotherapy, meaning I haven't seen a big efficacy difference between the two personally, but if you need prolotherapy of the posterior ligaments, that could be very helpful. But make sure that that's what.
Yeah, she did follow up. She says not injections. She's referring to ozone sauna therapy.
I don't have any experience with ozone sauna therapy. I really don't. So that one is going to be a hard one for me because I don't have any experience with ozone sauna therapy.
All righty. Thank you for your question, Elizabeth. Sorry we didn't have a better answer for you. Let's keep going with Lena. Follows up with, is there a long-term high risk of developing tumors from PICL after 10 years from the procedure?
No, we've done actually the world's largest safety paper on bone marrow concentrate. So there's 2 large safety papers on bone marrow concentrate. We did one, which has about 3,000 procedures in it. Felipe Hernigau did another one, which has about 1,800 procedures in it. Felipe Hernigau's paper was specifically on tumors, looking for tumors at 10 to 15 years out from procedures. There was no increase in tumorigenesis at all in bone marrow concentrate procedures. Ours looked at any complication, including tumors, and there was no increase in the tumor rate in those patients. So I think at this point, that one's been asked and answered with long-term data for bone marrow concentrate. There is no increase in tumor growth or formation, nor would you think there should be. At the end of the day, if you break a bone, it's bone marrow stem cells that end up fixing that bone. So obviously we don't see increase in tumors in people who break multiple bones. The Evel Knievel's out there that I don't know what he used to say. He broke every bone in his body at least once or something. But they're not more likely to get cancer than anybody else.
I think that's such an important point to just pause and make for everybody watching is that what we're talking about are orthobiologics, meaning that these are fluids, chemicals that your body makes with the specific intention of healing your own body. It is the ultimate personalized medicine, except the medicine is your own body. It's more healing than it is curing. And I know that, it's like, well, what's the difference? Tomato, tomato. They make all the difference in the world. Healing is something that is a process that happens from within, and we're just helping. Dr. Centeno is just helping. As chiropractors, we help facilitate the body to heal itself, which is different than a surgical procedure or a medication that has a different intention. You mentioned radiofrequency ablation. You can burn the nerves, have no pain. That doesn't fall into the category of healing. It's a difference. And these are the subtle differences that really give you your power back, because you then understand what outcomes you're looking for. All pain relief is not the same. Cutting nerves to get pain relief is not anywhere close to the same thing as helping the body heal itself so it's fully functioning and you're back to being pain-free. Those are not the same things, even though it appears that the outcomes might be very similar. Anyway, let's keep going with questions, and then we'll wrap it up in a moment. Jenna Swinger asks, is there a difference in how a muscle versus ligament responds to stem cells?
Yeah, that's a good question. I don't know that anyone has that answer. I can tell you a couple things. Number one is, for ligaments, we definitely see evidence in ligaments that we can easily visualize, like the ACL in the knee, for example, of evidence of repair on MRI after bone marrow concentrate has been injected. And that's what you would expect to see given the animal data, but we see that in actual patients. Then we get into muscles. The good news about muscle repair for bone marrow cells is that bone marrow concentrate is rich in hematopoietic stem cells, and muscles have their own stem cells called satellite cells. And when those satellite cells are burnt out and can't do what they're supposed to do, the body actually recruits hematopoietic stem cells from the bone marrow into the muscle to take the place of those satellite cells. So again, you would predict that there would be nice evidence of muscle repair. And we have seen that in select cases when we see muscle tears, inject bone marrow concentrate, and then take a subsequent MRI. But I can't say we have as much data and clinical data on that application as we do for ligaments.
All righty, great question. I love the thinking that's going on here. Kelly Bella asks the question, how do you determine how many treatments are needed? Is it based on response or by how bad your CCI is?
It's response. The goal is to give to you the fewest number of procedures to try to get from point A to point B. We usually, that's one of the reasons why we put in sort of an additional step of talking to the patient and seeing how far they've gotten before we'll approve another procedure. We could obviously just schedule 3 of them and say you're going to do all 3 or whatever, but we don't. After the first one, we'll meet, make sure we're on the right track, or if we're not on the right track, that the risk-benefit ratio is reasonable to try a second one, that kind of stuff.
All righty. Ilmas Ashraf, I hope I said that right, comments that he just did the PICL and he's noticing that his muscles are shifting. Is that something you want to comment on?
Yeah, so important to notice that most people would see relief within that first 3 or 4 months after a PICL procedure. Also to realize that there's that honeymoon period for that first 1 to 2 weeks where things are swollen and things feel better because they're tighter. So just realize both of those things.
Excellent. Dan is, everybody get your calculators, is calculating here the typical PICL fluoroscopy X-ray radiation exposure. I'll let all of you read the comment directly instead of getting into all the details there, but there's the data you're looking for, everyone. Jenna Swinger follows up with a great question. She asks, why do you recommend fusion instead of continued PICLs if no improvement after 2? She's wondering if you just relentlessly kept targeting those ligaments and muscles, they would have to respond eventually. I love the thinking.
Yeah, Jenna, there's a couple reasons. Number one is there's a cost component here as well. So we're trying hard to respect that for patients. Number 2 is we're not 100% sure that just keeping on would eventually get us someplace. That's certainly possible. But those are both of the issues where we're trying to advise people. And then the third is just there's obviously a frustration level that all patients have who have had this problem for a long time. Their lives have been turned upside down, and they want this nightmare to end as sooner rather than later. So those are the three things that we're looking at. Listen, I have learned some interesting things from patients who have been willing to continue when I didn't think something would work. So I have people, I've got one lady, for instance, with a facet cyst in her low back, and she's got the means. So, she just keeps coming back, and it's gotten better. I would have probably called it quits after the second one. We've done 5 or 6 bone marrow concentrate procedures into that facet cyst, and it has gotten much, much better. But again, she was willing to go on that journey and had no problems with going that direction, and just absolutely positively didn't want surgery. So at this juncture, now that we have a better idea of the safety matrix, if someone wanted to go on that journey and was okay with the cost of that journey and okay with the concept that we might not get on top of this, and okay with the concept that it might take a long time, then I'd probably take that journey and see, because I would love to know whether or not if you just keep hitting it, it'll finally get there.
It's a great question, and we'll sort of wrap it up with that. And I can tell you that, most doctors are going to err, or I should say at the Centeno-Schultz Clinic specifically, and I'll even say the Regenexx Network, are going to be more conservative in their recommendations. The last thing anybody wants is any whiff of we're making recommendations for the financial benefit or revenue of it. So all the doctors I've ever spoken to, part of the Regenexx Network, have always been ultra conservative in their recommendations, very much for the reason that you're asking. Is it's better to err on the side of nobody thinking anybody's taking advantage, that they're making recommendations that they have a high degree of certainty are going to help people get the value that they're investing in. Let's wrap it up for today. Kelly Bella says thank you. We say thank you. Doc, let's sort of wrap up. There's the PICL procedure. You invented it. It has helped many, many people get their lives back. It is only available at the Centeno-Schultz Clinic. There are 2 types. You can go from above the atlas, below the atlas. What do people need to know, Doc?
Yeah, so again, 2 types of procedure. One above the atlas targets mostly those upper alar ligaments and some other ligaments that we can reach from above. The one below the atlas targets the transverse ligament, the accessory ligaments, and the lower alar ligaments. We've done the one below more often than we've done the one above, but we are gaining lots and lots of experience with the one above. So these 2 procedures may start molding into or blending in to one procedure at some point. But again, we are cautious from a risk standpoint. We always try to see if we can expose the patient to the least risk until we know more.
That's our program for today. We really appreciate the questions. Thanks for engaging. Thanks for playing. Thanks for learning with us. That's what we do here. We love to learn. We love to teach, and oftentimes they're one and the same. So your conversation, your feedback, your questions really helps us really further the conversation. Get to hear from you what you're thinking, so we can keep bringing you great topics that are important and valuable to you. As always, if you're wondering whether you have any insurance coverage for any of these programs, you can go to the website regenexcoverage.com. There are up to 8 million of you out there that have coverage through your employers, specifically because they've looked for programs that can help their employees heal faster, better, cheaper, and easier than more drugs and more surgery that are dangerous and don't work. So you may be one of those 8 million people. Go to regenexx.com to find out. If not, you should take your health seriously and invest in it. Otherwise, you can always reach out to the Centeno-Schultz Clinic. There are always options available. So if this has been helpful for you, my one question or my one ask is, please share it with those people that you know would benefit from it. Most people find out about the Centeno-Schultz Clinic through referral and through watching programs just like this. People like you watching, going, that was fascinating, and turning other people on who are searching for help. That's the way we work together, help other people. We do it as a team, as a village, as a family, however you want to think of it. Dan, thank you for all of your help with the group. Of course, reach out to us anytime. Feel free to share these videos. And feel free to give us more topics that you know people are most interested in, and we'll keep doing our job and doing our programs as well. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. Thank you, everybody, for watching. We will not be here this Friday. Just so you know, on Fridays, we broadcast on the Regenexx page. Mondays here on Centeno-Schultz. Dr. Centeno and I will both be traveling Friday, so we'll see you next Monday right here on the Centeno-Schultz Facebook page. Thanks, everyone, for watching, everyone. Be well, stay kind, have a great week.
Thank you.